This is an age of disruption, of profound revolutionary change.
What we're really asking ministers is to empower the ambassadors.
The only thing that you really push forth is the truth.
You don't see many women represented when it comes to the decisions as to how to handle the pandemic.
Hello, I'm Joanna Roberts, Politico's health editor, and I'll be moderating this session on the crisis in the healthcare workforce. Now, the World Health Organization has said there's no health without a health workforce, and I think we really saw how true that was during the pandemic. And while the pandemic did put immense strain on our health system and our healthcare workers, it also brought many existing problems to a head. And I think there are two key questions that we're maybe going to tackle today. One, how do we keep the skilled, experienced people we already have in the system? And two, how do we get more of them? So before we begin, a quick reminder to ask your questions through the Swapcard app. And we'll dive in. And I'd like to thank all my speakers for joining me today. We have Sarada Das, the Secretary General of the Standing Committee of European Doctors. Michelle Folkenbach, a Technical Officer at the European Observatory on Health Systems and Policies. Paul de Rava, Secretary-General of the European Federation of Nurses, and joining us online, Thomas Zapata, the Unit Head for Health Workforce and Service Delivery at the World Health Organization Europe. So, in a way, there are so many problems that it's quite difficult to know where to begin. We've got an aging population, both in terms of healthcare needs, but also in terms of our healthcare workforce. There are fewer people coming in. The skills needs are changing. There's pandemic burnout. There are pay squeezes. There's a general feeling of a lack of appreciation. So maybe, Sarada, I'll start with you. Could you paint a picture for us just of what the experiences and problems reported by your members in terms of how do we retain them? What would they like to see?
Thank you very much, and also for giving us the opportunity to speak about this today. We really think it's very important to keep confirming that access to health is also more than access to medicines. We really need to ensure that there is a health workforce that is really the backbone of the health system, that keep it functioning. And you've already painted very much the picture that we're at, that we're really at the moment looking at retention, and we're looking at tackling problems which by far predate the pandemic. So this is not new in that sense, but of course is now in a situation where the fear is that medicine is losing its attractiveness as a lifelong calling. We see people leaving the profession, and we see very, very high burnout rates among those who are still in the profession. And a little bit the problem is that everything is connected to everything else. So we have to look, of course, for one, at the situation now acutely after the pandemic in terms of backlogs, in terms of health needs that were delayed, patients need care who maybe sought care late or are now being further delayed due to waiting lists, etc. But of course, we also have to look at the working conditions just very generally, how well do countries still comply with the working conditions? What is really the expectation towards the workforce? What is there in terms of workforce planning? All of these questions now arise and have become more urgent than ever, because we really fear that if we continue like this, we won't have functioning healthcare systems in the future.
Mm-hmm. And Paul, maybe if I could ask the same question to you, what are your sort of members telling you about their conditions and what's driving them out of the workforce, but equally what could keep them in?
Yeah, I think our biggest challenge at this moment in all the member states, which is in contrast to 5 years ago, that in all member states nurses are leaving massively the profession. They have enough is enough. In 2023, we have given all our energy in 21, 22, from day and night, and now we are totally up. We have no energy anymore to stay in this nightmare. So hospitals closing, emergency closing, intensive care units closing. That's the reality. Because not there are no PPEs or machines. There are machines enough, but there's nobody to put on the machine. The nurse is gone. And that is the reality right now. There are many reasons for that. We are talking about it already 20 years, but nobody cares. Nobody cares.
And if someone did care, what would you ask them to do?
I think the first thing is to make sure that we create our own domestic nurses, that we don't take a flight to India, Pakistan, Philippines, and fill that airplane with nurses. I hope the plane is not going to Africa, because there is only one nurse for so many people. And we are stealing that nurse. We are robbing Peter to pay Paul. But a few years ago, we saw Portuguese nurses going to Germany, and this is all done. All member states, all EU member states, 27, lost this year minimum all 10,000 nurses. Gone by the wind. Disappeared. So we need to invest in the education of nurses, to bring young people on board and try to keep them in the nursing education for 4 years. Because after 2 years in the education, they say, the students say, oh my God, what did I choose for a profession? It's a pure nightmare. So I'm going, please remember that nurses, young nurses are often women, huh? And it is very difficult to cope with such a difficult profession, coming home, doing the laundry, taking care of your kids, and a difficult husband, a mother-in-law, God knows what. This is the reality. And at some stage, enough is enough sometimes. And then nurses say, okay, keep it, the profession. Keep what you... Physicians are doing the same, huh? Don't worry. Huh?
Mm-hmm, mm-hmm. Maybe we'll pick up on that international element. If I ask Thomas, taking that sort of more global perspective, is the situation sort of the same across the board, or are there countries where it's worse than others? And also, are there countries that are doing anything right in terms of retaining healthcare staff, and how can that be emulated?
Thank you so much, Joanna. I think what we are seeing after the COVID pandemic is that most of the countries in the European region are facing challenges in terms of health workforce. And actually, we have seen strikes across the region and ministries of health really struggling with health workforce issues. What we have seen is that with health workers, if we look at the last 10 years, there has been an increase of 15% of the density of doctors, an 8% increase on the density of nurses across the countries, 37% increase in the production of doctors, 26% increase in the production of nurses. So it means that we have more doctors and nurses than ever. However, we still have this health workforce crisis. So the question is, what is happening? Why we have this? And the way we are explaining this is, you have mentioned these things, but I think on the one side, we have on the supply side, we have an increased attrition of health workers because of the aging doctors, for example. We have in 13 countries in the region, more than 40% of the doctors are over 55 years of age. That means that in the next 5-10 years, more than 40% of the doctors will go on retirement. So that's really pushing down the supply, the availability of health workers. And on the other side, what you mentioned before, the increased attrition, 55% on the health workers in the region with burnout. So that's really pushing down. And on the other side, what we have seen after the COVID pandemic is an increase in the demand for services because of an aging population, chronic diseases, increased expectations. So all this is really creating a health workforce crisis across the region in most of the countries. Of course, in terms of what to do, and one of the key issues that we see is, and you have mentioned it before, is improving working conditions. We need to really care and protect and take care of those health workers that we have in the system so that we can keep them. And for that, we need to reduce the workload in many cases because it's exhausting and it's too much. We have to look at the working hours, and we have to look at the mental health and well-being of the health workforce.
Okay, so hours and workload, those are two sort of key areas to look at. Michelle, what about you? From your perspective, where should we begin in tackling this crisis?
Sure, thanks so much for inviting me, and I'm very glad to be here. I see 4 challenges that we have with the health and care workforce today, and 3 of them were already mentioned. So we have retention, we have a recruitment challenge, we have a retirement challenge, and there's also a 4th, which is reactivation. And what I mean by that is getting people that were in the health and care workforce that have taken a break, whether through childcare or sickness or whatever other reason, trying to get them back into the health and care workforce. So those 4 challenges, and they're quite difficult to solve. They're big challenges. And one of the tools that we can use, perhaps, to start to address these challenges is something that I heard a lot about from the other 3 discussants, was planning and forecasting. And that can address a lot of these challenges that we're seeing. We need to know in the countries how many doctors, how many nurses, how many carers do we currently have? And not just in general, but very specifically, how many gynecologists do we currently have? How many are going in retirement in the next year, in the next 5 years, in the next 10 years? And how many do we need to train to fill that gap? And I was in Latvia last week, and I was speaking with a representative from Latvia there, and she was telling me that, yeah, they have databases. They have quite good databases. The Baltic countries are generally quite small, and so they are in more of a position to have a good sense of what they have and what they need. But one of the challenges that she then told me about was, yeah, we know all these things, but there are certain categories of professions that students don't want to go into anymore, for whatever reason it is. It's very difficult to train and to get students that are motivated into a certain direction. And so that's their particular challenge that they have to face, along with also a mass exodus after a medical student attains their degree. They leave and they go to a different country. And I just want to take another example of the United Kingdom, perhaps a bigger country, perhaps a little bit more difficult to get a database going there, but they do a fairly good job. They also do a good job of projecting what they need in the future. And there is a decent amount of interest from medical students, but their problem is that they don't have sufficient amounts of training programs. So they don't have the capacity for all the medical students that might be interested in going into that field. And so earlier this year, they released the Health Workforce Long-Term Plan, and they said that they were going to invest over $2 billion into the health and care workforce, and specifically also in training to make medical spaces more available by 50%, and to increase, as Paul was saying, the training, the domestic training of health and care workforce by 50 to 60%. So they're taking big steps to address that problem. And I think that the only reason they are able to do that is because they know what they have and they know what they need, and so they're able to fill that gap.
I mean, it sounds like a very simple concept, right? Counting who we have. Are you saying it doesn't happen and there's no sort of joined up idea of who actually is in the workforce, who we're going to need, who's leaving?
There is in certain countries. So certain countries do it better than other countries. Like I said, the Baltic countries are, because of their size, they're able to do it better. But there's other countries that just have such a database, perhaps for physicians. And they don't have one for nurses or carers, or let alone informal carers. There's just no tracking of how many people they have in their system. And that's quite a big issue if you want to move forward and you want to address some of these problems that the colleagues here were talking about.
Mm-hmm. Okay. Maybe we'll come into this idea that people aren't being really trained for what's needed. And I know some ideas have been floated, some innovations around things like task switching, so allowing pharmacists to do prescriptions, for example, to maybe ease some burden and also fill in gaps. What would be, I guess, a professional, sort of the medical profession's response to other people can do your jobs?
Well, also task shifting is not a new debate. It's been also around for some decades, and we have had a discussion on this for some decades. I think that from our members' point of view, task shifting, when it's really with the objective of improving patient care, safeguarding patient safety, improving quality of care, is something definitely that is an option and is discussed. But too often we see it being used to save money or to plug shortages that have appeared through underinvestment in other areas. And it is a bit of a fallacy to think that you can kind of fix doctor shortages with by shifting tasks to professions where there might be even worse shortages. So we really have to be careful that this doesn't just become a route to cheap medicine, and patients do not deserve that. So it's something where we think there is a discussion for it, but not as a solution to fix shortages as such.
Mm-hmm. Paul, did you want to come in on?
Yeah, I need to use this machine,
okay.
So that's good. I don't know why this on my ear is not working, but anyway. I think for the nursing profession, we have in the last 10 years moved on quite well in the sense of advanced roles for nurses, especially in a lot of member states, 19 member states. Nurses take up that advanced roles where you have the coordination of care in a holistic perspective. The other issue that we have been quite strong at, especially from Ireland coming 10 years ago, but now rolling out in the member states quite well, is nurse prescribing. So those are two concepts where in the coming 5 years we will try to look into the European Commission and to see how this will work out. Because our previous discussion on HERA was quite interesting when Kathleen van Brem said, yeah, I'm a politician, I'm a bad manager, but she forgets that she writes the legislation and that the nurses and the doctors are in troubles with the legislation that they put forward. So I would recommend the Commission to look into this issue, and I'm happy that Ursula von der Leyen at least mentioned us in 2022 in her State of the Union in 2023, you know, with all the problems that she needs to address. She mentioned the shortage of nurses and doctors. So let us focus down on the problem, let it solve it, because I am talking already since 2008 about data collection and biased data, the ILO not willing to receive, change the definitions of the data up till 2028. How can I plan with biased data? This is impossible. The OECD, the WHO, everybody is using data that is biased. So how can I plan this? But if my unit, half of the nurses left yesterday, I cannot wait for you, huh? I cannot wait for your planet. I need a nurse on the bedside, huh? And what governments from WHO are currently doing, creating cheap staff, cheap doctors, cheap nurses to fill in the gaps. Normally, by the European directive, you can only be a nurse after 4-year studies. Now, who cares? If you are 1 year education, 2 years education, come and wash, come and feed, whatever it is. Cheap, everything cheap. And that is the problem. So the problem is not task shifting between doctors and nurses. The problem is that there is no investment in the workforce to get high quality for what the citizens deserve, to be honest.
Okay. Thomas, did you want to respond to any of that criticism of the WHO?
Well, I think nursing profession is fundamental in the provision of healthcare services, as we know, and the nursing profession varies a lot from different countries. And I think from WHO, our position is clear that we need to really bring up the nursing profession to really have very high quality standards so that the nurses are really able to perform and respond to the patient needs on the ground. So in that sense, we are really supportive of that, and then implies a fair remuneration, and that's part of improving the working conditions. I think health workers, and when I'm talking about health workers, is about doctors, nurses, psychologists, and long-term care workers. I think we really need to make an effort in improving the remuneration, and that, of course, it also implies to increase investment. But I would like to make a point that I think another way that we need to, another action for the way forward, I think is about optimizing performance of the current health workers that we have. So that means that there is a lot of wastage also in our health services, and there is a scope to reorganize services in a more efficient way so that we maximize the time of the health workers so that they can really add value when they have a contact with the patient. And I think there is much scope for that optimizing performance so that really can maximize that time of health workers. And I think we have different examples. And in this one, we can use digital health technologies, for example, in order to support health workers in maximizing that time.
Okay, so if I understand correctly, you're talking about using sort of new technologies, maybe AI or whatever, to reduce workload on someone. What would be the response to that? I'll ask Sarah to come in and then Paul.
Thank you. Yes, I mean, of course, digitalization has huge potential, and we've been working on it also for many decades already. But just two things need to be taken into consideration. First of all, digital transformation done wrong actually reduces the number of patients that a doctor can see. This is the experience some of our members have had, that in terms of how many patients they can see per day, this actually time is taken up with the administration of the digital tools rather than direct patient care. So we have to be very, very careful about how we implement it. And this is very closely linked to my second point, training, and also talking about optimizing performance. CPME very, very strongly supports doctors' training, continuing professional development. It is a deontological obligation, but we did a study 10 years ago now almost, where we looked at, okay, what are the barriers to CPD for health professions across Europe, and something like 95% of the countries said for the professions it's time and it's cost. If there is not enough time and not enough staff to allow doctors or the health professionals to go and continue with training or to take training, then you have these gaps. And this is something which is very important now also with the EHDS, where we say there must be capacity and financing for training and also for providing the equipment to doctors. This cannot be left to individual practices to deal with.
Mm-hmm. And Paul, presumably you agree it's not a quick fix, it's not a panacea.
No, I think that, I don't know how long it has been that Thomas was on the bedside of a patient, but I remember my wife leaving every morning at 6 o'clock, coming home at 6 o'clock in the evening, and then having phone calls from the unit, on a cardiology unit with 90 patients, and then Thomas is coming. Can we talk about your performance? So it's the same as sending you as a journalist to Israel. You're running your whole day, putting your life in danger, because that's what the nurses are doing in the COVID period. And I'm asking you at 8 o'clock in the evening, when you have 5 minutes time to eat, did you perform well today? Should we look into this? This is unacceptable, and nurses will leave the profession if we keep on talking like this. The other criticism I have towards WHO, in 2010, all governments signed the ethical recruitments for not recruiting from other countries. Nobody cares. Today, they are all going to India. They are giving visas for doctors, for nurses. This is the reality. So there is a big gap between the theory, what is written in documents, beautiful graphs, and the reality outside there. People are suffering.
Okay, I'm just going to move away slightly from WHO, bring Michelle back in. It was halfway through the session, I think, when the question of money and pay raised its head, surprisingly. What's the role? Like, is it a budget issue, or how much of an issue is money in this sector, or is it more about how it's being spent, where it's being spent, and so on?
I think it's always a money question, quite honestly, and I think that's any sector you ask, they're going to say it's a money issue. I think we saw a nice beginnings of investment in the healthcare sector during the COVID-19 pandemic, because that's when all the attention was focused on COVID. And I think now, with all these other crises coming into play, we are slowly seeing a stop of investment in the health and care workforce, very slowly. And this is something that we want to prevent, obviously, because we know we need it in order to do all these things that we want, in order to retain nurses, in order to retain doctors, in order to recruit more, in order to train more, in order to reactivate more. We need to increase and keep this investment in the health and care workforce quite steady.
Mm-hmm. And I mean, recruitment is the sort of the second big problem that we talked about. And from the pictures painted, it doesn't sound like a very attractive area to work in. What can we do to change that? You know, what's the sort of one thing that's needed to get people's motivation back to work in the healthcare sector? Sarada.
Well, we've already said it's a little bit similar to retention. We really have to ensure that it is an attractive profession. And so, for example, we have seen in some countries that there have been sort of, let's say, negative policies to either keep people in the profession, or during training, that people were kind of bound to specific hospitals or bound to specific countries with sort of penalty system, where we think this is not a good way. So obviously we prefer to have positive incentives. We've seen some things that have success are just to have, for example, recruitment from rural areas. Then this to some extent increases the likelihood that people will go back to rural areas to work, for example. But as I said before, the general working conditions are, I think, one of the things which now obviously also is known to people who are looking for professions. And we had some positive effects after the pandemic that, for example, our Swedish members said that they had an increase in recruitment after the pandemic. So this visibility that the professions got, but then also the information about violence against doctors, about the burnout, about working conditions, all of this is also conveyed. So the sooner we improve this, the easier it will be also to, first of all, recruit people, but also to avoid that already very junior doctors leave the profession, which is what also is seen now. And we have to make sure that this is counteracted.
Mm-hmm. Thomas, as a sort of political level, did we squander the opportunity that the pandemic gave us to really value our healthcare stuff and invest and so on? And if so, how do we get the political sort of focus back on this very important issue?
I think that's a good point. During the COVID pandemic, as you say, we had a good window of opportunity, and actually there was a lot of societal support to health workers, clapping on the balconies and also investing a lot of money. But I think now that window of opportunity is closing down because of the different crisis that we are having in terms of war, in terms of financial crisis or economic crisis that we are having. So I think we need to be smart in how we make an investment case to ministries of finance and to governments, so that this critical investment in health workforce is maintained. And I think we need to really, one of the cases that we can do is that we have seen the consequences of not having well-prepared and resilient health systems when the pandemic come. And I think that's one of the arguments, so that we encourage to keep that investment in health systems. And the second one is that with the current situation that we have, with increased demand, with increased backlogs, the current situation of burnout of health workers, the current situation of high workloads, if we don't do anything, if we don't invest at the moment, the situation is going to get much worse. And that means that patients will not be able to have access to quality services. There will be delays, there will be waiting lists, and that will have an impact on the health of the population. And at the end of the day, in the economy, I think we need to change the mindset that investing in health is a waste, is a cost. I think we need to change that mindset and convey the message that investing in our health workers and investing in the health sector has a good return on investment, and it's a wise investment for a society. So I think between all of us, because I want to say that I think we are all in the same boat here: civil society, academia, health workers, World Health Organization, other organizations. I think we are all in the same boat to go in that direction.
And Michelle, I mean, it seems like probably no one in this room would disagree that investment in health has a good return on investment. Why is that message so hard to get through at a political level, do you think?
It's difficult when you have multiple different crises happening at the same time. Like Thomas was saying, if you have a recession, if you have wars, if you have a society that wants security, the last thing, perhaps, unless they're suffering from a medical condition on their mind at that moment, is investment in health. And that's something that we just have to push through, because health is what makes us all tick every day, is what makes us go out and have the nice lives that we have. And it's a difficult concept to have, because we take it for granted most of the time. We take our health for granted. We take the health and care workers for granted. So we don't think about that this particular sector needs increased and constant investment to make it function the way it does.
Mm-hmm. And Paul, what would you say to someone who doesn't think it's worth investing in healthcare workforce?
Now, I never met people who said it's not worthwhile investing in it. So I'm a nurse 40 years. And I was telling to Petra a few minutes ago, what kept me in the profession, and also my wife, who is also a nurse, is that you have a contact with your patient. I was a neonatal ICU nurse, having these small babies of 1 kilo 2 in your hand, and they are so strong and they communicate with you. You don't understand how this fills up your battery for a full month. My wife is a cardiology nurse in a small town close. What fills you up? That is that you have that contact with your patient. I remember when I was 17 years old, my first dying patient. It was strange for me. It was very strange. I was very young. But now I remember the power to have somebody see dying and making sure that you're staying with that person until the very last moment. That gives you energy. That is the beauty of being a nurse, a physician, whatever in the healthcare sector. And so for that, you need highly educated nurses and highly educated doctors. And those two professions are the core business around the patient bedside. Digitalization will not replace us. I cannot send a robot to a dying patient. Please don't do that to us. So in that sense, we need to be more holistic. We need to be less performance measurement. The stories that I hear them already from 2010. If I look at the council conclusions from 2010, the Belgian presidency, I read them a few days ago. I commit to this, I support this, I blah, blah, this, I blah, blah. Nothing changes. In 10 years, 12 years, our problem became 4 times double. I remember commissioners. I survived many commissioners in my career. They all said, we need to bring the health minister together and the finance minister together. Up till today, nothing changed, huh? So can we please, Thomas, change the rhetoric of our story? Can we do something different so that we are not getting more and more into the shit that we are today?
Okay.
So I'm calling Ursula von der Leyen. I hope she's watching us, huh? Because we need her to put this as a priority in the cabinet next year. If not, we don't survive.
Okay, so health needs to be a commission priority for the next mandate. And I'm going to ask all of you this question. I wanted one thing for the EU to do, so that's yours.
Voila.
One thing that can be done, one single thing that you would like to see done at a member state level that would make a difference.
Me.
Yes.
I want EU legislation and to make sure that the member states implement it. Not like in WHO, signing beautiful declarations and going home and doing exactly the opposite.
EU legislation saying what?
EU legislation to plan the workforce, to make sure that you have enough nurses, safe staffing levels at EU level, so that we know how many nurses at what bedside we need, how many doctors, and pay for that. That's the only thing we need. Okay. And we need it now.
Thank you very much. Thomas, I'll ask you for one action, maybe you agree with Paul, one action that can be taken at the EU level and one action that can be taken at member state level to help.
I think a concrete action that will help a lot is that currently we are not able to measure burnout, intention to leave in the health workers in the EU countries. There are different tools, they are not aligned. So I think it would be really helpful to have a standardized mechanism tool that is the same across the EU countries, that we monitor on a regular basis, so that we can monitor the effectiveness, the impact of policies to improve the burnout, to improve the working conditions, and we can show and see the results of the effectiveness of those interventions, because I really believe that it's critical that we care the health workers that we have, and we need to be able to show the impact of those interventions, just as a concrete measure.
Okay. And Michelle, can I ask you the same thing? If you could choose one policy, what would it be?
I think at the member state level, I would like to see more investment in health and care workforce education and training. I think that's quite important. And moving beyond the EU level, more towards the societal level, just a greater appreciation from individuals towards the health and care workforce. I think that would go miles.
And how do we encourage that?
We start with each and every one of us and just basically be thankful for your health, and when you have to go in and see a health professional, be thankful for that person that is helping you and taking the time to do that.
And Sarada, what one policy measure would you like to see?
Well, one policy measure that we tried to promote very hard during the negotiation of European Health Union legislation was to have improved the data collection on the health system's capacities, and for the Commission to issue recommendations on minimum capacity levels. So data is being collected and it's being presented, for example, with WHO by the Observatory, and being presented in a very neutral way, although it was very clear that member states have made decisions which mean that they are underinvesting in certain areas. If you look at the countries that have the lowest ICU capacities, for example, you will see that this is not really often issue of there not being enough money, just a decision not to invest in these areas. And the healthcare systems are very different, so we can't have like one number and this is it for the whole of the European Union, but we need to have really better guidance on be able to say this is not safe. This is not a safe staffing level. This is not a safe level of resources. So our window of opportunity that you mentioned during the pandemic, unfortunately closed on this. We thought this would be something that would really stabilize systems beyond just dealing with pandemic preparedness. But this is something that we really hope will be revisited at EU level. At national level, I think one major catalyst which was visible during the pandemic and is now gone is really high-level political interest. We've seen it before, but leaving the health system to talk to itself. No one disagrees, as you were saying, no one disagrees that we need more money. And the problem is that the people who are involved in the discussion do not have the leverage to really move this ahead. So we saw that where there is really top-level political interest in health and the whole government working together to promote health, that change can happen very quickly and very impressively. And this is something where we have to try and regain part of the spotlight, let's say.
Mm-hmm. And it feels like, I know we talked earlier, that it's really not about sort of making things new and shiny and futuristic. It's really about getting back some of the standards that we used to have. And actually, it's much worse now for, I think, Paul, you were saying as well, for people now who join the profession, they see a profession that they don't want to join. So how do we make it a... what would success look like?
Can I jump on that? Oh, sorry.
Okay, go on, Thomas.
No, for me, success is that health workers can live their life, they can have a good work-life balance, so that they can be with their families or with their friends, so they feel that they have enough space for that. And at the same time, they have a working environment that allows them to really perform the profession of their dreams. I'm a family doctor. I have all colleagues, nurses, long-term care workers. What you want more than money is to be able to deliver and to make an impact in society, in the patients you have in front of you. So what we need is systems that allow you to make that impact, and at the same time, a system that is protecting you and allow you to have a work-life balance, and you are not working 60 hours a week, for example, and it doesn't allow you. So for me, that's kind of the two main goals that we'll put over.
Okay, we've got a minute left, so maybe a quick fire question to all of you. What would success look like?
But I think that we are prepared for the next pandemic. And that's why HERA is so important. Because if we are not prepared for the next pandemic and it will come to us, I don't know what to do anymore, to be honest. There are now today no nurses anymore, not in the community, not in the hospitals. So I don't know what's going to happen. So we need urgent action. We need less documents, less paperwork, less data collection. But we need to do something concrete, frontline, to make sure that we are prepared for the next pandemic. That would success look like.
Okay. Michelle, very quickly.
Protection for the health and care workforce, whether that be through training of the health and care professionals against violence that's done towards them, and just strategies as to how also to deal with stress that they may have, burnout and the likes.
Sarada, one word.
There's a lot I agree with. Maybe one word is long-term thinking.
Okay, thank you very much. All right, well, thank you very much to all my speakers. I think we've worked out that there's a lot to do at a very basic level, including just counting how many healthcare workers we have. But thank you very much, everyone, for joining me today. Next up, we have a sponsored segment on behalf of our partner PPTA, followed by our final panel on Taking Europe's Pulse on Plasma with Helen. So please welcome to the stage Thomas Kryl, Vice President of the Global Pathogen Safety from Takeda. And please remain seated while we just change the stage. We can exit.